All right, welcome everybody. My name is Jesse Schold, and I'm here to introduce this session. This lunch symposium titled Molecular Precision Testing, How RNA and AI May Guide Kidney Transplant Management. We're very pleased that the session today is sponsored by Thermo Fisher Scientific and Veracity DX. On behalf of the American Society of Transplantation, I'd like to thank Thermo Fisher Scientific and Veracity DX for their support of the CEOP meeting. We're excited for everyone to be here. At this point, I would like to please welcome our speakers. We have four esteemed speakers as part of this symposium. I would welcome you to the stage here. You all have your technology set up for you, so if you would please come to the stage, it would be fantastic, and we will kick off this very interesting session. I'm getting, okay, all right. Okay, all right, that sounds great, yep, thank you.
Hi everyone, I'm Sarah Barrington. I'm the CEO of Veracity DX. Here's my colleague Tina. She'll be doing the introductions as well. I think the term AI in recent years has been dominated by some headlines around language-based models, such as ChatGPT. But in areas such as engineering or healthcare, for decades we've been using mathematical models to develop the underlying technology. Let's take the example of cars. More computer than engine these days, I understand. The average car has, between 30 and 50 computers on board, 100 if you're a luxury driver. And for enthusiasts, popping the hood, peeling back the dashboard is fascinating. But for drivers like myself, we're more interested in the safety and the performance improvements that come from that technology as we get to our destination. In that spirit, today's fireside chat is pitched at that. We've asked clinicians who are drivers, users of the technology, to come and share with you some of their experiences. So I would like to pass over to Tina, but before I do that, I'd like to make an invitation. Anybody who is an enthusiast who would like to pop the hood, as it were, to understand how we use these mathematical models in gene expression in unsupervised training sets, how we ensure the stability and the reproducibility in our analytical validation studies, and how we use highly inclusive study designs in our clinical validation to ensure performance. Please reach out to the teams at Thermo and Veracity. We'd love the opportunity to come and give an educational meeting with you. Thank you.
Thank you, Sarah, and good afternoon. My name is Tina Lidke. I'm the president of Thermo Fisher's Transplant Diagnostics business, also known as One Lambda. For over 40 years, our company has been a leader in HLA typing and antibody detection, which, as you all know, is really critical for successful transplantations. That said, we know that the HLA system is just part of the equation, and with that, what we're doing is offering clinicians more tools to not only enable successful transplants, but also ensure that patients live longer, healthier lives post-transplant. So with that, we are happy to be partnering with Veracity DX to provide a novel biomarker, a novel RNA gene expression assay, which will help predict patients' risk for early acute rejection. We believe that this technology is really promising and can lead to potentially improve long-term graft survival rates, as well as allow clinicians to offer a more personalized approach to immunosuppression management. So with that, I'd like to welcome you all. I hope you enjoy the discussion. And as Sarah said, if you are interested in hearing more about the technology, welcome you to come by either the Thermo Fisher or the Veracity booths after the session. I'd like to thank all of our speakers today and introduce our moderator, Dr. Prince Mohan Anand. Dr. Anand is the Director of Transplant Services and Program Medical Director at the MUSC Health Transplant Program in Mid-Carolinas. He earned his medical degree from the Medical University of Pleven, Bulgaria, and did his postdoctoral training at Cornell University. Dr. Anand went on to complete a nephrology fellowship at New York Hospital Queens and finished his general nephrology and renal pancreas transplant fellowship at Columbia University. Welcome, Dr. Anand.
Thank you so much for the invitation and the opportunity to come here and talk to my colleagues and friends. Some of you know me from my WhatsApp group, so those of you who are tortured by it, I'm sorry. But that's one way we transplanters keep in touch, especially the transplant nephrologists. As mentioned earlier, the purpose of our meeting today is to talk about things that are coming cutting edge, right? That's the whole theme of our meeting is cutting edge, to talk about things that are either here now or they're going to come in the pretty near future. And of course, AI, as mentioned earlier. If you had listened to the talk about AI a little bit ago, I was fascinated by a mathematician there. My wife is a physicist, so sometimes she talks about it, I get lost. I was like, I don't know what's going on here. But mathematician telling there about AI was very, very interesting. I think we are in the era where our clinical field is going to get immersed with AI. So if we keep on resisting, I think we'll be losing a lot from our clinical perspective as well. So I think AI will be part of us, whether we like it or not. As mentioned, ChatGPT, people are writing their emails with ChatGPT. I know our university has given us a AI tool within our Microsoft. So we're doing a lot of things AI that we might not even realize. So that being said, my goal today is to set the stage for our esteemed speakers so that they can come in and do their job. So that's me. These are the disclosures of our faculty. I'll leave it for a few seconds for you to read about them. What are the learning objectives today? Our learning objective is to see what is the role of mRNA signatures, both in the pre and post-transplant setting with Petra and Tutivia from Verici, and how these tests are being used by our speakers who have the experience with these tests, and they are on the papers as well for this test. And how does research, essentially suggest that Petra and Tutivia may enhance risk management in kidney transplant patients? So, one of the reasons that I took transplant over nephrology is because I thought that a lot of things are happening in transplantation. In the last 12, 13 years, we have seen a lot of things happening in general nephrology as well. A lot of things that were idiopathic, now we know what is the reasoning behind. So, but in transplantation, we can see that from organ innovation, we have done so many things. We created UNOS. We came to machine perfusion things. And as you guys know, that we have got a bunch of machine perfusion going on. We have done our xenotransplant, Actually, it was in news that the lady from Alabama who got the transplant with Bob Montgomery at NYU, she just went home to Alabama, which is, again, great success. And then we have gotten better with our immunosuppression as well. We are doing desensitization. Our rejection rates have gone down because our immunosuppression has gone better. And then we have got the standard of care testing, creatinine, everything else. When it comes to biomarkers, we have got HLA, we have got the GEP and cell-free DNAs, and now we have got mRNA signatures which are actively using AI. From personalized to precision medicine. When medicine started, it was one bill fit all. Everybody will get the same thing. Then we learned that, if a person is trembling with a cyclosporin level of 250, it might not be a good idea. So the people who were before us doing transplants, that's how they found out if cyclo level is enough or not. If the patient is trembling, the level is enough. If the patient is not trembling, the level is not enough, right? And thymo was called shakes and bakes. So the surgeons knew that thymo is working because patients will get shakes and bakes. So we learned more and said, okay, this is not going to work. Let's come up with some things that will protect the patients. And then we slowly came to personalized medicine. And we have moved forward from personalized medicine to precision medicine. And the perfect example that comes to mind is oncology, right? In oncology now, people have specific markers, and they go after those tumor markers and make sure that those specific targets are those specific targets are going after. And same thing now in transplantation as well. As we go forward, you will realize that we are in the field of precision medicine. And this just goes and explains as to what is going on now. You've got precision medicine now, where you have Petra, which is a pre-transplant mRNA-based testing that tells you what is the risk factor or risk score of this patient, whether they're high risk, low risk. Then they get transplanted, you give them therapies, and then you see how they're doing. Now, just to switch quickly gears, rather than being a reactive community and turning to a proactive community, that is looking at injury markers versus risk stratification markers, right? When you look at the injury markers, you are looking at something that has already caused injury, and then you're moving forward from there. Whereas prognostic markers or risk stratification markers are telling you this patient is at higher risk of injury, this is what you can do for these patients, so that moving forward, you can decrease immunosuppression, increase immunosuppression, and things like that. What are the injury markers? Serum creatinine that we have used for a very, very long time, or EGFR, proteinuria, and you've got cell-free DNA. When we come to risk stratification markers, HLA, like applet markings, matchmaker, things like that, organ quality, ECD organs that, or what we will call high KDPA organs that we see all of us, cold times, and we have got the RNA signatures of Petra and Tutivia. What is Petra? Petra, as I was saying earlier, it's used prior to transplant. It's pre-transplant risk assay, and it gives you, it's an mRNA-based assay that will give you whether the patient is high risk or low risk. And Tutivia, similarly, is a mRNA-based marker that is post-transplant, will tell you if the patient has got high risk or low risk of rejection. With that, I'm going to request our speakers to come up. First person is Dr. Zara Hajiri. We have got the whole crew from Chicago. So I don't know how that happened, but such it is. Dr. Hajiri is at University of Illinois. She has done her med school at University of Jordan, did her residency at Henry Ford, and fellowships at, where did you do a fellowship? I forgot.
University of Massachusetts.
University of Massachusetts. And she's the medical director of kidney and pancreas transplant at University of Illinois. We have Dr. Javed Ansari, who is a clinical researcher at Northwestern Memorial Hospital in Chicago. He has done his postgraduate fellowship in transplant immunology in Harvard and transplant fellowship from Brigham as well. He's also affiliated with medical school. He has done a lot of work, and his interest is in immunology. Last but not least, my good friend Sanjeev Akina. He is at Loyola University. He's the medical director there. He got his medical degree from University of Kansas School of Medicine and did his fellowship in Minnesota. His research interests are improving kidney transplant outcomes through biomarkers and immunosuppressive therapies. I'm really grateful for the Chicago-based crew to be here and be part of this great symposium. And sorry in advance for if I push you at times. And thank you. So with that being said, I would like the pre-transplant risk assessment to see what is going on in the pre-transplant world. I would like Dr. Zara Hajiri to tell us what are we doing currently in the world of pre-transplant and how we can move forward.
Thank you, Prince. So, can you guys hear me? Yes, okay. So for the world of pre-transplant, the way we discuss our patients, and we all know this, we look at recipient characteristics, and we look at donor characteristics that would indicate the high or low immunological risk. So for the recipient, we can talk about sensitizing events, such as, 10 pregnancies, 5 or 6 organ transplants. Those are all sensitizing events that would increase the PRA or the CPRA in the blood of the recipient. Hence, it would make it more difficult to get a transplant, and the risk of rejection would be higher. Some programs also look at the recipient age, ethnicity. Those are all factors that we have traditionally looked at to risk stratify our patients. And with time, we're slowly identifying that that's not enough. Maybe we need more. Maybe we need something else that could help us identify that risk pre-transplant. which is essential because sometimes we may think, oh, this is a high-risk patient. Let me give him thymo, 2 other inducing agents, put him on quadruple immunosuppression. 3 months later, they are on tons. They have BK, they have CMV, multiple infections. And another patient, that's the exact opposite. So with that, I think I'll give the... So what's new?
Thank you, Zara, for explaining to us what the current lay of the land is for pre-transplant risk assessment. I have been fortunate enough to be part of a study that developed the pre-transplant risk assessment assay test. And I'm going to be sharing some of the unpublished results. Because it is unpublished, I'll be brief, and in the interest of time, because we have a lot of other things to discuss as well, I'll be brief. But see me or the team from Thermo Fisher and Verici for details, and look out for the paper hopefully soon. So this test was developed by including run-of-the-mill standard patients that we see day in, day out in our clinical practice. All comers were included in the study. And the study was restricted in this analysis to deceased donor recipients only, deceased donor kidney transplant recipients. And a blood test was drawn within 24 to 48 hours of transplantation at the time of their pre-transplant labs. And that blood test was subjected to next-generation gene sequencing for mRNA analysis, and with the use of, as alluded to before, unsupervised machine learning algorithms. A set of genes was assigned. 29 genes were identified to delineate the risk of rejection early post-transplant. So the analysis was restricted to first 2 months post-transplant. And what was found was that as I mentioned prior to going into the details of the results, you can see that the slide here may be difficult to read, but I'll just mention that it represented a broad spectrum of the patient population that we treat, including all races and ethnicities, different geographic areas across the world, different risk profiles pre-transplant in terms of number of transplants, HLA mismatches, PRA, and different underlying kidney disease were included into the study. What the test results showed us briefly is that the test using 45 as a risk score for cutoff, the risk score is depicted as 1 to 100, and using 45 as a cutoff to predict risk of rejection within 60 days post-transplantation, the hazard ratio, the number of times the risk of rejection was 7 times of those that had a low risk, the ones with high risk. So that's a very high risk of rejection in somebody who had a high risk score. This was on a pre-transplant sample. And the negative predictive value was very high for low risk score recipients, up to 96%. And you can see the AOC is very good, pretty close, 2.8. And this suggests that this test has the ability somehow to actually add on to what we already have, that Zahra detailed, the pre-transplant risk assessment tools, to identify those individuals who are at risk of experiencing a rejection early post-transplant. And one might wonder as to why this might be, and it's just, and what is interesting is that this is a recipient-specific test, agnostic of donor information, HLA information, donor type. So, we really don't have to consider the donor at all. And it's something to do with the recipient status at the time of the transplant, based on the timing of the test. Now, one could extend the timing of the test and see if this test holds true for much before the time of the transplant, to see if similar to what the current tools we have, like PRA and so on and so forth. But in this study, we're able to say that right at the time of the transplant, the gene expression profile at the time the recipient is going to receive a transplant determines their risk of acute rejection early post-transplant. So with that, I think there's going to be, I'm sure, a subgroup analyses of the data to delineate as to what subgroups will benefit and how this test might be used in the clinic. And I envisage that this could be used in the early post-transplant period to modulate immunosuppression, where we currently use a standard immunosuppression, and if we know that the risk is low in an individual, then we could potentially decrease immunosuppression that might pose a risk for complications such as BK virus nephropathy or other infectious complications soon after transplant, and even long-term complications such as cancer in the long-term follow-up of these patients. Another area that one could envisage usage of this test is that we're sort of quote-unquote flying blind in DGF in the period, where the creatinine is high, the slope may be declining, but it could be even steeper if there is no rejection, so there could be rejection lurking in the background. So having a test that could tell us the risk of rejection post-transplant, independent of what is happening to the transplant function, DGF, will also be good, but that I think needs to be seen. So with that, I will pass on the mic to Zahra to actually discuss how it might be used. And if anybody has any questions about how the traditional risk factors performed with this test along with this test or as an add-on, analysis of the study data suggested that the Petra test was independent predictor of risk of acute rejection, independent of the traditional risk factors. So here you go, Zahra.
Thank you, Dr. Javed. It's Dr. Sanjeev who's going to discuss.
Sanjeev's going to talk about, yes, yeah, let's go ahead.
Sorry, so I'll go back to our experience where this initially was introduced to us way back, probably over a year ago now. And it was, we had Thermo Fisher and we had Verici come in and talk about kind of the early results were, I think, stemming from the trial that you guys were involved in, and maybe I think some of the data from the ASN presentation that you had, maybe 23, I think it was. And we were excited by the idea of can we find ways that we can identify patients that are truly high risk for rejection? And for our center specifically, we have as probably many centers with protocols with using combinations of either basiliximab, low-dose thymo, high-dose thymo, based on a variety of conditions that Zahra had mentioned earlier in terms of PRA and pregnancies and so on. So we thought, well, this would be kind of an interesting way to find out, can we try to minimize our use of thymo and use more basi in certain situations, or even just low-dose thymo in those cases? So we were very excited by this idea of potentially using Petra for something like this. So when the discussion came in, it came up to the idea that this is actually a test you get at the time of transplant. So that's where you actually have to draw at the time of transplant, and the turnaround time we were told is somewhere around 3 to 5 days. So we're like, okay, well maybe we can't necessarily do it for induction therapy yet. But there's still some potential where we could do it for maintenance immunosuppression down the road. So maybe we can identify those individuals that could maybe we can cut back on their mycophenolate at 30 days. Or maybe we can reduce their FK goals earlier instead of waiting 3 months like we typically do at our center. Or potentially, if those individuals are just described as high risk, maybe we put them on prednisone. As a center, we do rapid steroid withdrawal for our program. So we thought about all these potential things, but then I think one of the issues that we kind of ran into was when the test is getting drawn in the hospital, we were worried about how does that affect our DRG. And as this discussion was with our surgical director, he was not excited about the idea of potentially an additional cost going on to our DRG for this. So, we're like, okay, well, what can we do to potentially see, can we get this test earlier? So it was mentioned that maybe it was done a few days, 28 to 48 hours. Living donors, obviously, I think you can do that. You could potentially get this test maybe 3 days, 4 days earlier and do that. So maybe there's a little more predictability with living donors. But again, for focusing on deceased donors, which at our center is a large population, we had to figure out, is there a way to get this test, can this test be done 3 months earlier, 6 months earlier, maybe even up to a year earlier? And are these results stable? Are these results stable enough to say that a test that was drawn a year ago could potentially work as our pre-transplant assessment? So that's kind of where we're looking at exploring the idea of looking at individuals that are either preemptive, your ESRD patients that are either on hemodialysis or PD. We're looking at a longitudinal study to potentially draw these samples at quarterly over their time on the wait list, and then potentially also a group of patients that are scheduled for living donor transplants, where we typically have them come in a couple of weeks before their surgery for their pre-op labs, and then potentially another one at the time of transplant, and compare what is the evolution of the signal of this score, essentially, of their risk assessment, and is that going to be applicable to help us decide maybe we can determine induction therapy using this risk assessment score. So it's kind of where I think we're looking at that. I think there's also, as you mentioned, other conditions that we need to look at. What about DGF? How does any potential perioperative and post-transplant things affect the applicability of the score to risk assessment? So I think there's still a lot to be learned, but we're hoping to learn more about potentially if we want to use this in deceased donor transplantation. How do we identify this? Is this a score that we can get even before the transplant to maybe apply this in a wider range of cases?
Yeah, thank you. Thank you for that insight.
Thank you. So if I can summarize that the study was done and the test was drawn at the time of transplant, and Sanjeev, you are doing a prospective study that is drawing blood at 3 months, 6 months, and things like that. So we'll get some information based on that. And we also have a living donor arm that's going on where they will do the study 4 or 5 days before, and based on that, try to make the changes in immunosuppression. Great.
Exactly. Yep.
That's great information. I would like to open the floor for questions from audience, please, before we move to the post-transplant realm.
Yeah, Bernard Zimmerman from Natera. I just have a question for clarification. Is this a test of the donor? Because you pointed out living donor, you can do it 3 to 5 days before, or the recipient, or both?
Let me take that question. It's a test that is recipient specific. Just the recipient blood is analyzed. No donor is involved. The only reason the donor is coming into the picture is the timeline for the test result to become available for actionable items where, like in deciding induction therapy, then I think it needs to be done before, but it's a purely recipient-based test.
Dr. Rajalingam from UCSF.
Thank you. So how stable is her 29 mRNA signature? Because we should know whether the alloimmune response when you put the kidney, whether it's going to trigger. Is this all part of whether it's stable or fluctuating?
I think that's an excellent question. Stability post-transplant or even stability pre-transplant, as Sanjeev is trying to address, so that we can have a priori knowledge of the risk going into transplant well in advance so that we can plan immunosuppression, perhaps even plan donor selection and things like that. We don't have the data. I think this is a one-time test that it was done in close proximity to the transplant event. So I think more studies need to be done both before transplant and after transplant with this set of gene signature to determine the risk of rejection.
Thank
you. John Lunds, LifeLink Transplant Immunology Lab in Tampa. Very interesting concept here. Have you investigated in patients where you may have to cross a known donor-specific antibody, this test result, and whether or not if it could stratify patients that are responders, might have a memory response post-transplant versus those that might be more quiescent and that DSA might not respond quite vigorously after transplant? It'd be quite interesting to have that information to potentially stratify, DSA into 2 categories based on the recipient's relative ability to respond.
I'll let Sanjeev answer. I mean, we both could, but.
I was going to defer to you because you had the study, but I think the study that is where I think some of the preliminary data was presented, or the unpublished data, I think that potential to understand those individuals that have those preformed or those memory responses and seeing how that may affect it. So I think certainly there's a lot to be learned from the information in the study that was conducted earlier. So, but it's a great question though.
Thanks for that. John Maltzman from Stanford. This is really a measurement of immunological risk. You've looked at it in kidney transplant. Has it been looked at in other solid organs, and would you expect it to be the same for those 29 genes, or do you have to go back and do your machine learning for other tissues?
That's an excellent point, John, as always. I think the study was restricted to kidney transplant alone, but certainly I think if it pans out and continues to show similar results in the real world, I think that definitely other organ transplant, multi-organ transplant it's a novel tool. I mean, it really is a leap forward from what we have. Not to mention that we have had donor-specific antibody and PRA, particularly donor-specific antibody and PERSH and epitopes and eplets. They're highly specific and precise, and this sort of adds the next level of definition for immunologic risk, recipient-based immunologic risk prior to transplantation.
Thanks.
Richard Knight from Houston Methodist Hospital. So you talked a lot about how this assay could isolate a group of patients at high risk of rejection, but we all know that most patients that we take care of are not going to suffer rejection. It would seem to me that this would be really useful to isolate a group of patients that you could relatively comfortably institute a regimen of immunosuppression minimization. Could you speak towards that?
No, I agree completely, because the positive predictive value was not high and the negative predictive value is so there is a great value in that. I think at the time of transplant, if we get the result in a timely fashion, induction therapy decisions, and then post-transplant, decisions to modulate immunosuppression and minimize as much as possible to avoid harm is the goal. Yeah.
I think it's all extrapolation based on the study that we have done. We don't have all the data at hand, but as Dr. Akina will be doing his study, a prospective study, and we'll have some further data from living donors as well. I think all those questions should be answered, but those are all brilliant questions. So thank you everybody for your questions. With that being said, I would like to move on to the post-transplant realm and see how mRNA-based signatures can help us out.
I think as been mentioned before, I think you mentioned where potential markers that we're using in our post-transplant surveillance. I think historically, creatinine, EGFR, DSAs have all been kind of traditional methods of what we do to monitor post-transplant care for these patients. And of course, in the last 5 to 7 years, we've been adding in cell-free DNA as another monitoring tool that we use to kind of help with determining kind of the health of the allograft in a way we can kind of ultra immunosuppression or consider even biopsies in some of these cases. So I think where we want to look at is other potential, but there are certainly some benefits and there's some disadvantages of different tests that we use, and we have to kind of work with that, and we all understand that as we use these tests that there are limitations for it. So I think there's some potential opportunities where there may be additional biomarkers that may actually offer even kind of help fill in those gaps that we're seeing, and I think we'll have Zara kind of talk about that a little bit. Or sorry, Javid, sorry.
Yeah. I will introduce the Tutivia test that you referred to, Sanjeev. Thank you. Again, I was fortunate enough to be part of the study that developed the Tutivia test, which again is a mRNA signature involving 17 genes that were developed in a similar fashion to the Petra, using unsupervised machine learning, arriving at a 17 gene set and determine the risk of rejection post-transplantation as early as 1 week.
Dr. Javed, can you please forward the slide? Sorry.
Yeah. As early as, here we go. So the test was developed in such a way that post-transplant samples were collected in kidney transplant recipients who were all comers, similar to the previous study that we talked about. They had all ethnicities represented, all immunologic risk were represented in the study, and all kinds of induction therapy, including T-cell depletion therapy, ATG, thymoglobulin, CAMPATH, Simulect induction, and all kinds of immunosuppression were included in the study. The test was done at 1 week, 1 month, 3 months, 6 months, and 12 months. Protocol biopsies or surveillance biopsies were done at 3 and 12 months, and for-cause biopsies were done, and the pathology was read by central pathologist, and the risk score was established for acute rejection anytime after transplantation, either detected on surveillance biopsies or for-cause biopsies. And a risk score of 50 or above was defined as high risk, and a score less than 50 was defined as low risk. And using this cutoff, the test performance was evaluated in a validation study, and the study has been published, and I think you may all have the opportunity to review it, but I'll briefly summarize the test results or test performance as shown in here. The AOC was pretty good, approaching high 0.7 value, and the negative predictive value was also even higher, specifically, and the risk of rejection with a high score was more than 5 times compared to the ones that had a low risk score. So this test, again, is a tool that is available to us in addition to the pre-existing tools that are available for us to immune monitor the kidney transplant patients post-transplantation. We've all had the opportunity to use the test after it has been made available to us. We all have different experiences. I think would like to share those. I think having a test that has a high negative predictive value, again, gives us, as quite nicely mentioned by one of the audience members here, is that to assess the risk of rejection, but more importantly, to enable us to modulate immunosuppression. And I think that's where this test would be useful. And there are situations where the test has been utilized by my colleague Zahra here, and I'd like Zahra to elaborate a little bit more as to how Zahra has used the test. Go ahead, Zahra.
Thank you, Javed. So before I start talking about my experience with this test in a DGF patient, I'm going to tell you a small story. So I am not very young. I've been in this for quite some time. When I was a fellow, that was years and years ago, I was training in a lab. It's a kidney transplant lab. And reading about biomarkers. Biomarkers then were a thing where not a lot of them were commercialized. Again, I'm not very young. And I wrote an IRB. And I submitted it, and it got approved. What am I looking for? I'm looking for RNA expression in PBMCs. Very, very, very ambitious fellow that looks like 12 years old, walking around, wants to extract blood in PBMCs and create a signature marker. I was done with my year of fellowship. Unfortunately, I had to do some waiver, got buried with 10 clinics a week, 25 inpatient services a week. Time passed by. And a year ago, maybe a little less than a year, our director calls me. I'm in the middle of clinic, and he tells me, Zahra, I want to introduce you to someone. The IRB is still there. Not a single patient has been enrolled. I'm like seeing patient nonstop in clinic. So I want to introduce you to Verici. And I'm like, okay. Well, they have a very good biomarker. And you may be interested in it. So I sit down, and the first thing that I'm told, it's mRNA. And I'm like, okay, I'm listening. It's whole blood. Oh, okay, great. And we're looking at the transcriptome. Okay, now we're talking. So let's see what that test is all about. So as Javed has mentioned, 17 genes gives you a risk score between 0 to 100. And based on that, you can risk stratify into high risk and low risk. Okay, we've had that. What else? Well, you can do it as early as 1 day post-transplant. That's good. 1 day post-transplant gives you an expression profile. What else? Well, it has the ability to differentiate other pathologies, BK, other infections, acute rejection. Great. So a few months ago, we started accepting part of the IOTA. Everybody knows IOTA. Everybody knows, hey, we're going to accept more marginal kidneys. We need to increase our numbers. We can't grow kidneys on trees. We can get them from animals now, but... So DGF clinic opened up at UIC, and we're doing more and more DGFers. Those are sleepy kidneys. I don't know if this kidney is rejecting or it just has ATN. I don't know. Patient's not making urine, creatinine is up. So we decided using some biomarkers that help guide us. So I'm going to talk about one of the cases that helped guide us, and where Tutivia guided us in making some decisions. So, real case, hold on, where do I go? Back. The red one, right? Okay, here you go. It's much better. So, 68-year-old Hispanic male. He has hypertension as his presumed primary disease. He gets a cross-match negative deceased donor transplant sometimes in December of last year. Now, KDPI is high, 92%, and it was a DCD kidney, and it has a decent warm ischemia time and a decent cold ischemia time. Pre-implant biopsy showed a 13% glomerular sclerosis. There is decent arteriolar hyalinosis. And this patient has some weak pre-transplant DSAs. Perfect storm. Excuse me. All our DGFers get thymo induction. And he was discharged stable, but on dialysis, about 4 days post-transplant. He was placed on prednisone, Invarsus, and mycophenolate. We are steroid sparing, but this patient is clearly high risk, so we've placed him on prednisone. He was started on belatacept 2 weeks post-transplant. Now, hypothetical Petra at 22, that's the low risk. DSAs at week 2 and 3, they're stable but moderate to high in intensity. The Tutivia on week 2 was 12, week 3 was 32, the score. Donor-derived cell-free DNA, week 2 was 2.1, week 3 was 1.1. The imaging showed some fluid collection, simple. And this is the timeline. So 0 is time of transplant. There's no arrow, right? No arrow, okay. 0 is the time of transplant. And then you have weeks post-transplant, half, 1, 1.5, 2, 2.5. And that's the creatinine. And then between 1 and 2 weeks, that's where the DSAs were. Tutivia was 12, cfDNA, cell-free DNA was 2.1%. between 2 and 3, DSAs remain positive. Tutivia is still within low risk score. Cell-free DNA has gone down at 1%. Patient doesn't open up. He still doesn't make much urine. He's still on dialysis. So we got to biopsy this patient. Now, this is a relatively new test. Let's test its ability. So mild to focal arteriolar hyalinosis, arteriosclerosis, there's diffuse atrophy and interstitial fibrosis. Our pathologist was thinking this is donor-derived. With a BANF score, the only inflammatory marker is very mild acute glomerulitis, and our pathologist had to really dig through it to give me that AG1 score. He's like, I'm not convinced, Zara, maybe not. I'll just put it there. Okay, I'll take it from you. So what do we get out of this? Maybe I shouldn't have biopsied this patient. All the risks were low, but I was really bothered by those DSAs. They're like, oh gosh, is he really rejecting? Am I rejecting a kidney that already has a lot of scar tissue in it? I don't know. So I did biopsy him, and this happened. So, and this is not only one example. We have a DGF clinic where we get these scores every week or every 2 weeks, and we track them, and we make decisions based on them. And we submitted recently some data that looks at DGF and early slow graft function patients with the use of this particular test. So I'm hoping everybody attends.
So Zara, how did
WTC.
this patient do long-term, do you know? Or he's still at week 4, or it was a recent one?
What's that?
How did this patient do? How long ago was he transplanted? Do you have any updates on this patient?
So because of the chronic findings there, and he had quite a bit of dialysis time, he has some kidney function. He started making some urine, but his creatinine clearance is still less than 20. So we did call him as a primary non-function so that we can give his time back. So he's not doing very well, but not because of rejection.
Yeah, no, I think the point you bring out is that should we have biopsied or not? The biopsy was useful from another perspective to assess the long-term outcome, but I think there was no clear evidence of rejection, going hand in hand with the Tutivia low-risk score and also the track test coming down. Initially was high, but we know that track could be high early on. After transplant may not be very helpful in interpretation, so I think that's one potential use of the Tutivia. And like I mentioned before, we've been using Tutivia in a separate population of post-transplant patients, another difficult area of post-transplant management, which is people who are at risk of BK nephropathy or BK infection. And again, the transplant community is looking for guidance as to how to modulate immunosuppression, and I'd like to sort of share my experience with BK cases, and I have brought along a representative case where a lady, a 60-year-old lady who has type 1 diabetes, actually, very well preserved, and she got to 60 with very little complications, but unfortunately had kidney disease, therefore received a kidney and a pancreas transplant a few years ago. Unfortunately developed BK nephropathy, and we cut immunosuppression as best as we could, knowing the pancreas is functioning, and that was important for her, so we couldn't really go really low with the immunosuppression. Eventually the kidney failed, but the pancreas was still functioning, and she was lucky enough to get eliminated living donor kidney transplant a year or two later. And while she was on immunosuppression, she'd fortunately cleared her BK viremia. There was some low-grade BK viruria. We transplanted with Similac induction second time round to minimize the risk of BK relapse. Nevertheless, with the escalated immunosuppression at the time of transplant, the second transplant, the BK viremia increased, and we were now faced with this challenge. And she was really nervous as to, what would happen to her second kidney transplant. She didn't want to lose that, and being diabetes-free was important to her. But this time around, going back on dialysis wasn't very appealing. So she had requested us to do everything possible we can to try and keep the two transplants going, but more importantly, prevent her from going on to dialysis. So I think what we did was we tried to use all the tools that we had at our disposal, and one of them was fortunate enough to have access to Tutivia, and we did the Tutivia test a few times in her, and each time the Tutivia test result came back as low score, that allowed me to actually push the immunosuppression as low as we can, and we managed to clear the BK viremia. In fact, now the BK viruria is actually low level. Both transplants are functioning well. So I think, I want to bring out my personal experience that the more tools we have to assess the immunologic process that is going on in our transplant patients, then we can, safely and confidently reduce immunosuppression without running the risk of rejection. I think I've gone through the case verbally, so I don't think you need to follow the slides. So I think so that's where we are with the post-transplant, potential usage of these new tests. I'll let my colleagues to chime in and see how would they.
So if I may summarize, essentially what the test is telling you where the immune system is setting at, and if you're getting a test score that is low, it gives you a confidence, so to speak, that the immune system is pretty quiescent. And in the case of BK, that you can decrease the immunosuppression. And in case of delayed graft function, if you're looking at a quiescent immune system, you're not worried it's a rejection. You're not going to go after biopsy for rejection reasons. But as all of us transplanters, we know that we are getting 70-year-old DCDs now. So we just biopsy them for the reason to find out what exactly is going on, if we have to change the medications from CNIs or something else. And on the other hand, if you have got a higher level above 50, that would make you worried that immune system is not quiescent at this point. You ought to do something, whether it's biopsying or changing the immunosuppression, things like that. Would that be an accurate statement, more or less?
I think so. I think these are the potential ways that people can use these novel tests that are available to us. And one could serially do the tests and follow the test scores to see if the immunosuppression modulation is affecting the immune response and putting the patient at risk for rejection.
At this point, I would like questions from audience as well before I go on and ask a bunch of questions. So please.
Actually, before we get started, I was just curious. So, sorry for your case, where you, I know you didn't have the Petra score, but if it was a low Petra score going into that case, and then they go into DGF, do you feel that, would you just felt comfortable? Like in the cases I usually see, a lot of these individuals that are DGF 2 weeks out, they start to have a lot of diarrhea from their 720 of myfortic I give them early on. You have a low Petra score in that case. Would you feel comfortable enough to say that you could probably reduce the immunosuppression in the setting that you also have these Tutivias that are also suggesting that it's a low risk for rejection after the transplant in the setting of DGF? Do you feel comfortable that continuum might be helpful, or do you feel like that's something to look at?
So yes, definitely. So there is a portion of the case for time's sake, which is the patient did develop an infection, and we started weaning immunosuppression off because we really didn't want to harm this patient. But yes, we did act on that. So I think this continuum where you have this biomarker that is pre-transplant that tells you, hey, the immune system is quiescent, right? after transplant, whether it's DGF or any other complication, you have another biomarker that tells you, listen, the immune system is still quiescent. And then the patient tells you, doc, I'm having like 15 bowel movements. And you're chasing it around, or they develop a BK or a CMV, you'll feel, okay, I feel good. I'm going to maybe reduce the immunosuppression, be more comfortable, because I have markers that tell me the immune system is quiescent. There is something that could guide me, other than the extremes of disasters, right? We get this with transplants, where we wait for bad infections, reactionary, right, Prince? Let's drop the immunosuppression. A terrible rejection, again, reactionary, let's add 5 extra drugs. So having that would definitely help. So.
There's a question there.
Oh, go ahead.
Sarah, this is the case you presented. So there's a DSA, preformed DSA, DQ around 7,000 MFI, but your Petra score is low. So that means the DSA is not included in the equation of Petra, correct?
So
It's hypothetical, just disclaimer. Yeah. That Petra score is not a real score.
Oh,
Wasn't available.
But let me, I know you asked the question earlier, which is, I'm sorry, Javed, which is PRA and Petra, and my understanding is when they created this algorithm, or this score was created, when they added PRA to the algorithm, it didn't change much. So it's as if it's embedded in the score itself. Does it make sense?
The score did not change whether,
You
based on
added
PRA, whether
or
your PRA
not.
was 100 or your PRA was 0,
didn't
it did
add
not
much.
change the score.
So that means it is not counted, correct? It is not included in the, it is included, but the Petra score is not affected by the PRA.
Yes, that's
Okay.
exactly what it was. Yeah.
Got it.
Yeah.
So the second question, very quick. In post-transplant, the 17 signatures, so how do you include this HLA mismatch, level of HLA mismatch and pre-sensitization, other factors? That's the one going to trigger autoimmune response. How do you pull that into the equation of calculating the post-transplant score?
I mean,
Javid?
Yeah, I can answer that. I mean, in the study, there was no difference with the mismatches and any DSAs that were present. So the score was not affected by those factors.
you're talking about the Tutivia or the Petra right now?
The Tutivia.
Tutivia.
Yeah,
okay.
I can see
You're
both are
confused.
same. Correct?
That's
This is true. It's a gene expression profile, right?
Yeah.
They got the blood, they get the whole blood, and they got it through a mathematical equation, artificial intelligence, and they got the score. They got a specific set of genes pre, and then they got a specific set of genes post. So concept is almost similar.
So the way AI worked was the samples were taken from patients who did not have rejection and who had rejection, and then the genes that were different were mapped out, and the 17 genes were the genes that were taken as the significant genes. What the company did, and you have to talk to them more because, as you can imagine, I'm not an immunologist like yourself, Dr. Rajalingam. I'm the clinician, so I actually rely heavily on my HLA people to guide me. But the way the company worked was they took 17 hub genes that have upstream more genes, so to speak. So these 17 genes were taken in that sense that while we are looking at 17 genes, but you might be able to get more than that effect from those genes. So they were independent of everything else, but definitely they were different among the group that had rejection and did not have rejection, if that makes sense. Thank you.
Hi, Dhiren Kumar from VCU. Going back, I'm sorry I missed the first 10 minutes of the talk. How was early acute rejection defined in the first study?
in the first study, Petra, within the first 60 days, 2 months.
Okay. And how many incidents of early acute rejection was there?
From the top of my head, I think it was about 30%, if I'm not mistaken. But
30% of acute rejection rate?
overall, subclinical. Don't quote me on this, because the study is not published, so I don't know exactly. Maybe someone else, if remembers, maybe. I don't know the exact
percentage. I think 30%
percentage.
biopsies were done. Out of those 30% biopsies, out of 35 biopsies, I think there were 20 positive, so 20 were rejecting. So out of 150 patients, there were 20 patients who had rejection. So close to 12, 13%, including subclinical and clinical.
Yeah, I think one comment I had with respect to the Petra score and taking just the recipient factors into account. The incidence of rejection is almost an evolution as to what happens to the recipient, as in the kind of induction that they get, as in the infectious complications that lead to reduction of immunosuppression, and the ability to tolerate immunosuppression. So I guess that's where you would claim that the Tutivia comes in to play. However, it's in your case, a lot of centers would biopsy that patient, and what argument I'm trying to make is that even though we are coming up with all these markers that say don't biopsy and stuff like that, you cannot not biopsy a DGF patient. It just, there are so many other reasons to biopsy other than rejection, which is a very small factor, especially in the first 60 days. I mean, you're looking at a 5% rejection rate in most centers. So I wanted to know, what niche do you see for this test in a space that is already being saturated with a lot of current biomarkers?
So, it's a very good question. So, before I talk and tell you what the niche is for this test, especially in the DGFers, maybe a month ago we had a DGF patient. Now our center does a lot of robotic transplants. And when it's robotic, it's intraperitoneal. And I have this DGF patient, obese, kidneys intraperitoneal. The scores are persistently low, has very low-grade DSAs, and he's still in DGF. And I've been wanting to biopsy him. So I eventually called my surgeon. I'm like, listen, I'm going to bring him over. He's going to come on a Thursday, or did I say Wednesday? Biopsy him on Thursday. We'll get results by the end of the day, because the biopsy has to be done in the OR. Patient comes in, drives 4.5 hours to get to UIC. We go to the OR. He picks up the phone in the OR, and he tells me, Zara, I can't find the kidney. Like, I want to do it laparoscopically. The patient's obese, and the kidney is in between bowels. I don't want to mess around here, because how strong do you want me to pursue this biopsy? And I'm like, I've seen how many DGF for that day. I'm on service. The service is big. I'm like, let me remind myself. I go through the chart. Scores low, scores low, scores low. Okay. Don't biopsy him. So I don't biopsy him. 2 weeks later, actually 6 days later, the transplant nephrologist, who's my colleague, telling me, listen, Zara, you did a therapeutic biopsy. I was like, I didn't biopsy this guy. I was like, well, whatever you did, it was therapeutic. The patient's making urine, his creatinine's down to like 1.8, 1.9. I think we're good here. I'm like, that's great. So those are one of the last cases that we had. And I know this is not common in the community. This is not a lot of centers will face, intraperitoneal kidney, bowels, can't biopsy it. But I think with the push nationally for us to increase numbers, we will get into a situation where, do I really need to biopsy this kidney? All my DGFers get biopsies at 3 weeks and then every 3 weeks, and probably everybody else here. But we're in a new era right now. An era of needing to take higher risk, either technical or organ type. So we have to up the game post-transplant with screening. So I'll give you that. long answer, but I hope I answered it.
I think it's a fair point that there are situations where we want to biopsy, for example, risk of recurrent disease, or look at the status. If we don't have a donor biopsy prior to transplantation, you want to see if how much donor disease was there. But all of those, I think, could be just one-time biopsies. But then if you need serial monitoring and ongoing monitoring, this is where I think the test is useful.
And I was just going to add, I think when you're asking about like where do I see this test, and from my perspective, I think we were exploring the use of it because the one I think we really struggle with are like not only just DGF but slow graft function, the one that where the creatinine is just kind of stuck and it's slowly coming down, and and trying to find the right biomarker that can actually maybe potentially has a better positive predictive value early on. I think may be where I see this test maybe perform a little better than what we have out there. So.
I think we can all attest to the fact that, not to mention the New York Times article, I'm pretty sure some of you will have visceral reaction, especially if you take the organ call and you know what it takes to wake up at 3 o'clock at midnight, and at 3 o'clock in the morning, I should say, and then go to UNOS and look at what the hell is going on with this donor, and then find a recipient to put the kidney in. And then, the kidney is going to be DGF because you're getting this kidney at sequence number 3,595. And these are the organs that we're going to see more and more, whether we like it or not. Everybody's under push to do more transplants. OPOs are being held under fire that you have to do more transplants. If you don't meet certain criteria, we're going to take your contract away and give it to the next OPO. So they want to do more. They want to do more donors. We are getting more, marginal organs. We are listing more marginal recipients. That combination is not going anywhere, and it's a day-to-day reality. Unless you trained in New York City, 12, 13, 14 years ago, where I trained, and our standard cold time was 36 hours, and Lloyd Ratner would transplant anything that comes through the gate. Hope he's not here, otherwise. But he will take it as a badge of honor anyhow, right? So if you're anywhere else in the country, right, South Carolina, where I was there, cold time was 6 hours, 8 hours. If it gets to 20 hours, they would start trembling. And I think Dave is here, and Dave can tell you that I'm right? 24-hour cold time, they were like, oh my God, what is this? I came from Colombia, I was like, 36 hours is standard? You've got kidney at 18 hours of cold time? This is great. They're looking at me, I'm crazy, I'm looking at them, they are crazy. But with the changing realities, as Zara mentioned, I think we have to change how we're going to practice. And all these tests that we are doing, they are going to help us with one way or another. And we just have to find the use for these tests and to make sure that they are there. The goal is to do more than 60,000 transplants by Expeditious Task Force. And then we have this goal of 1 kidney for life. There are some days when I wake up and I look at the offers that I'm getting, and I'm trying to reconcile the two, goals that we have set in front of us. And I do not know where I'm going, right? The part of me that is taking the offer wants to use that kidney, wants to put it in somebody where it will be useful. And the part of me that says 1 kidney for life holds me back and tells me, don't put this in a 45-year-old. It's a bad idea, right? Find a kidney that you can put it in a 70-year-old small lady. Maybe this kidney will last her for a few years. The point I'm trying to make is that these are the decisions that we make every day, right? And if some of those decisions can be made easier by, hey, this person does not need biopsy because FXYZ is going on. Let's take a look at this pre-transplant risk score. This person is lower risk of rejection. Let me put this kidney in this guy who is lower risk of rejection, smaller person, rather than putting this marginal kidney who has got very high risk of rejection with high scores and a big guy. That kidney is not going to last them for a few days, and then they might become PNF, and you get flagged, everybody gets flagged, even though, the OPTN has come out and said, and SRTR, that we're going to make it 2.25 rather than 1.5, but your insurance companies are looking at us and like, oh, the kidney failed, we're going to flag you, we're going to come back and take your center of excellence, away from you. So all those things, when you look at it, all I can say is that the world of transplant is very complex, and it's not going to get any easier for us because we are under the microscope at many levels. SRTR, insurance companies, now patients, now New York Times is coming after us. You know, it was not enough that CMS is after us, now New York Times is too. But I think these tests hopefully can help us putting the kidneys in right people, and if not for life, at least get the maximum life out of these kidneys that we can. I think that's the goal. Unfortunately, I'm saying that it's not one kidney for life, but that's where we are at. With that, I want to say thank you to everybody, and I apologize for my last 2 minutes of venting, but I think it's coming to a culmination that this is where it is. At this point, I would like our speakers to give us one take-home point about these tests, those you guys think are important. Sanjeev, please go ahead.
I think from my perspective, I think the biggest thing is that we're still trying to understand the roles of these tests and how they work with all these other biomarkers that are out there. So I think it's still a learning process. I think there's still a lot of work that needs to be done to look at this. But I think the potential is, I think certainly adding more biomarkers to help us identify anything to help improve graft life and is going to be important.
Dr. Javed.
Yeah, thank you. And I'd like to echo what Sanjeev is saying, is that there's a lot to be learned and improve on what we have. I think the test looking very promising in the studies and in our experience before wide usage of these tests. And I think as our moderator has elucidated in the last few minutes, we're having to work and do more with less. So I think these are the tools to make lemonade out of lemons.
Jara?
Well, you guys said everything. Time to move on. Time to move on from older markers, biomarkers, and think more in a sophisticated manner where transcriptome matters, pre and post, mRNA, what your body is telling you, what this patient's body telling you immunologically matters. So personalize, precision, I think this is where we need to go in the future. And that's it.
Thank you so much to our speakers, and thank you to the audience for listening to us and for your participation. If you have any questions, please feel free to grab one of the presenters or come to the booth for Verici and for Thermo Fisher, and we'll be happy to answer all of your questions. And thank you again.
Thank you.